Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with prostate cancer? Find out more right now. My guest this evening is Dr. Sean Collins, Associate Professor with MedStar Georgetown Medical Center. Sean, welcome to Housecall.
Thank you for having me. I'm excited to be here.
My guest this evening will be discussing what's new with prostate cancer. Sean, tell us briefly about your professional background.
Well, the thing is that I actually had the good fortune of attending the University of Michigan and doing both an MD and a PhD. Then I went on to come to Georgetown and I did a surgical internship and went on to complete my radiation oncology residency at Georgetown. And I've been an attending here for the last 15 years and I love my job. I get to work in the best city in the world. And I get to take care of men with prostate cancer, improve prostate cancer outcomes, both improving the cure rate, improving quality of life after, and making it more convenient. I couldn't be in a better position.
And most important, you got away from the Michigan winters.
By the way, I fell on the ice the last day I was there, so I don't miss it.
There you go. So briefly, tell our viewers, what exactly is the prostate gland? What is its physiologic purpose?
You know, the prostate gland is only in men, and it sits between the bladder and the penis, and it's where your urine goes from the bladder through the urethra, which runs through the prostate out to the penis. But more importantly, it's very important in reproductive anatomy. So it helps form ejaculate. So when sperm come from the testes, they go through the prostate, and ejaculate is added to the sperm to make it more viable for making children. So basically, the prostate was an organ that was meant to be important for about 50 years of life expectancy. Unfortunately, we are now living into our 80s and 90s, and the prostate unfortunately becomes damaged over time, and prostate cancer is a disease of aging. I always talk to the robotic surgeons at MedStar Georgetown University Hospital, and they always think about maybe they should be doing prophylactic prostatectomies on 50-year-olds. I'm 53. I think I'll hold off on that.
I do agree it's unfortunate if somebody develops prostate cancer, although I don't agree if somebody, as you said, unfortunately lives to be 80.
I don't know. You look pretty good, man. I think you're going to make it to 90.
I hope so. Anyway, what exactly are the symptoms if the prostate is malfunctioning?
Right. So, the fact is that you don't know that you have prostate cancer until it's too late. There are no early symptoms. If you develop late symptoms like obstruction, where you can't urinate and you need a catheter placed into your bladder, or you wake up one day and you have bone pain or pain in your back due to prostate cancer, it's too late and you're not curable. In the Washington, D.C. area, 1 in 6 men will get prostate cancer. It's actually the highest incidence in the United States of prostate cancer. So it's really important that we do screening in this area to make sure we find it early so we can cure men of this disease before it causes their death.
How common is prostate cancer compared to other cancers like breast cancer, lung cancer, colon cancer?
It is the most common non-skin cancer in men, so it's really common. One of the struggles we have is that probably 200,000 men in the United States a year get prostate cancer. Roughly a similar number of patients get breast cancer and lung cancer. The problem with prostate cancer is that although there are 200,000 men diagnosed, it only causes a death in 30,000 men a year. So, how do we know which men need treatment and which men don't need treatment? That's one of the big challenges in prostate cancer because we want to make sure that those 30,000 men don't die of prostate cancer, and we don't want to cause side effects of unnecessary treatment in the men who are not going to die of prostate cancer.
There is, as you alluded to, a broad spectrum of prostate cancer patients. And some of these cancers are very slow growing, and others can be very aggressive, even in a young patient. Is there any biologic work that's been done to determine if the tumors are different biologically and genetically, or is it more the patient themselves in terms of their response to the cancer?
Well, the thing is that prostate cancer has a very long natural history. So it starts off as low grade prostate cancer and then over years becomes intermediate grade prostate cancer and then converts to high grade prostate cancer. It's the high grade prostate cancers that cause your death. There's actually a staging system that divides prostate cancer into low risk, intermediate risk, and high risk. The low risk cancers generally have PSAs that are less than 10, Gleason scores that are 6 or less, and you cannot feel them on digital rectal exam. So the PSA is a blood test that you can just check by getting blood from your arm, and it's a good marker of what your risk for having prostate cancer is. Every man over the age of 50 should be getting a PSA once a year. And for men with high risk of prostate cancer, like African American men or men with high levels of family history, they should probably be getting it once a year starting at age 45. We check their PSAs. A lot of men are actually diagnosed with low risk prostate cancer where they have low PSAs and low Gleason scores, and we actually do nothing in those patients. We actually just watch and monitor and make sure it doesn't progress to higher grade cancers when they need treatment. Some men can be on active surveillance or watching for years before they get treated. Generally, then, like it eventually will progress into what's called intermediate risk prostate cancer, which is very curable either with surgery or radiation. What we want to try to not let happen is men progress to the high risk group, which becomes less curable.
You mentioned risk factors. Is there any genetic risk or any racial risk for prostate cancer?
Well, the thing is that African American men have a higher risk of getting prostate cancer than other men, but it's probably multifactorial and it's poorly understood. In my clinic, I commonly see men, African American men, about 10 years before I see Caucasian or Asian men, which is actually sad because they're in the prime of their lives when they're diagnosed with this illness. Other work is being done more recently that there are actually patients who have mutations in germline DNA. And these patients usually have very extensive family histories of breast cancer and prostate cancer, specifically women getting breast cancer at a young age. 1 out of 10 men who develop prostate cancer actually have a mutation in DNA damage repair genes, and they might need more screening than the average group. But we're studying that. Actually, I'm blessed that I get to work at MedStar Georgetown University Hospital because we have a great team of researchers who are studying what the role of these gene mutations are and how we surveil men.
Are there any other risk factors for prostate cancer besides potentially genetics?
So aging. So the older you get, the higher chance you have of getting it. Family history, genetics, African American men. Some people think that diet might influence prostate cancer. I personally feel that men who have prostate cancer did nothing wrong. They were just living their lives and they got unlucky. And unfortunately, they got to an advanced stage and they developed prostate cancer. And we should try to help them.
How about smoking and alcohol? Are they risk factors?
Right. So smoking and alcohol are risk factors for things like lung cancer, pancreas cancer, but they have a low connectivity to prostate cancer.
I know for a number of years it was said that frequent sex would reduce the risk of prostate cancer.
I agree with that. Although I have no scientific literature, I do agree with that statement.
Okay, and I certainly agree too. But the data does not necessarily support it.
The data does not support it. There's never been conclusive studies that say too much sex or too little sex causes prostate cancer.
Okay. You mentioned several times the PSA, which for our viewers stands for prostate-specific antigen. As you know, that was controversial a few years ago. There were some statements where it was challenged, and there was concern that a positive PSA would lead to undue anxiety and testing for the patient. And then I guess those concerns have been allayed. It's now popular again. Is that
It
correct?
goes in cycles. When they do a lot of testing, 20,000 men die a year. When they do little testing, 40,000 men die a year of prostate cancer. So it's definitely a balancing act. One of the things I love about PSA testing is, there's no size fits all. So we're supposed to have a discussion with the patient and tell them the risks and the benefits of PSA testing. And they're supposed to make a personal decision about whether they want it or not. Before you offer a PSA test, you always have to think, does this person have a life expectancy of 10 years? It generally takes 10 years from the diagnosis of prostate cancer to death from prostate cancer. So if someone has severe heart disease, if they have dementia, maybe we shouldn't be ordering PSA tests because their life expectancy is less than 10 years.
What are some of the sorts of treatment available? And then we'll go into them in detail in the second half of the show.
So a very common treatment is robotic prostatectomy, or surgically removing the prostate. That's generally for younger men. For older men, generally we do different forms of radiation. IMRT, or intensity modulated radiation therapy, is one common one. Proton therapy you hear on the radio all the time because there's lots of proton centers in our area. There's a procedure that's actually very good called brachytherapy, where you put 100 radioactive seeds in the prostate. And I'm a world expert at a thing called SBRT, or stereotactic body radiation therapy, that is most commonly given with robotic radiosurgery or the CyberKnife.
And what about chemotherapy?
Chemotherapy is rarely used early in prostate cancer. We use a lot of hormonal therapy. So prostate cancer, like breast cancer, responds to hormones. So men have high levels of testosterone, which is great. It's good for their muscles, it's good for their bone, it's good for their sex drive, it's good for their energy. But unfortunately, it makes prostate cancer grow. And one of the first treatments that we do for advanced prostate cancer or metastatic prostate cancer is lower the testosterone. And in patients with prostate cancer, if you lower the testosterone, the cancer goes into remission for years. It's not a cure, but it relieves symptoms.
We're going to pause right there.
Great.
More with our guest, Dr. Sean Collins, discussing the newest information about prostate cancer. We're going to pause now for a public service announcement. We'll be right back. We're back. My guest this evening is Dr. Sean Collins of the MedStar Georgetown Medical Center, and we're discussing the latest therapy for prostate cancer. Sean, when we paused for the break, you gave a nice overview summary of the different treatment options. And now in the second segment of the show, we will drill a little deeper into each of those. So tell our viewers briefly what is involved with robotic surgery.
Right. So robotic surgery is generally for young men with long life expectancies, because removing your prostate is probably the best way to get long-term cure. So it's a surgical procedure. There's no big incisions. There's little tiny incisions. And the surgeons, this is your prostate, your bladder, your rectum, and your penis. They take their little robots and they cut, they pull your prostate out. They try to spare the nerves that control your erections. They anastomose your bladder to urethra. and you wake up at the catheter. They take the catheter out a week later. Everybody leaks on themselves for a few days, few weeks. We're lucky at Georgetown that we have some really good robotic surgeons and usually don't leak for too long. Um, the two nerves that control your erections are a little bit challenging to spare. So usually your erections don't work very well until about 6 months to a year after. But if you have high quality surgeons, usually your erections come back. They give your prostate to a pathologist to examine it after they're done the surgery. And that pathologist will put ink around your prostate and then look for cancer on the margins, which basically means when they were cutting, they don't see the cancer. And every once in a while, there's a few cancer cells left on the margins. And some of those patients will need radiation months to years down the road. With that approach, prostate cancer is highly curable, and the chance of recurrence in where the prostate used to be is low. Unfortunately, some men are unlucky and they are left with urinary incontinence for the rest of their lives. There are approaches to helping with that problem, and good robotic surgeons, that's relatively rare. Sometimes sexual function does not come back, and you will need help from a urologist to use different approaches to improve your erectile function if you're motivated. Thank God we have urologists because there's lots of different approaches for the motivated patient.
Okay. Well, let's go on then to discuss radiation therapy.
Okay. So when I started a radiation oncologist 15 years ago, the accuracy of radiation wasn't as good as it is today. So your prostate actually moves as you're sitting here. Like Dr. Doman, your prostate's probably moving right now. Your bladder is moving up and down. So your prostate's moving up and down. Your rectum, you have no control of when your rectum moves. So your prostate moves back and forth. And even worse than that, it can actually rotate on different angles. So in the past, when we set up radiation, we would set up to the prostate, but we didn't track as we were treated. So we had to use very large treatment margins to make sure we didn't miss. Unfortunately, your bladder, your rectum, and your penis are right next to your prostate. So they ended up getting a lot of dose of radiation, and we had to give a little bit of radiation each day to kill the cancer cells. But the normal tissues like the bladder, the rectum, and the penis could repair. But it meant like patients would come for like 40 treatments over 8 weeks. An alternative that we used to use commonly is instead of making them come for 8 weeks, is we used to do a thing called brachytherapy, where we put a lot of radioactive seeds directly into the prostate, which overcame that problem of having a moving prostate. The problem with brachytherapy was it was very user dependent. So it was very technically challenging procedure. And you had to make sure you covered every last inch of the prostate. I used to do a lot of it before we had the CyberKnife. And I always felt like for every 10 procedures I did, 7 went great, 2 went so-so, and 1, I didn't feel very good about. And I don't like not feeling good about my chances of curing a patient. So 15 years ago, when we first started using the CyberKnife for prostate cancer, the CyberKnife actually sets up to gold markers and then tracks as it treats, and treats with 150 different beams of radiation. So it's the most accurate radiation in the world. It has sub-millimeter accuracy. It tracks prostate motion, so you can treat with very small margins, which means that you can actually give the radiation faster because you're not treating a lot of bladder, rectum, and penis. So you can give the radiation in 5 treatments over 2 weeks versus giving it over 40 treatments. Most of my patients are still working at age 70, 75. They don't want to come for 40 treatments. They prefer to come for 5. And the secret is that 5 treatments are actually more effective than 40 treatments. If you give 5 treatments highly accurately, radiobiologically, it is more effective than giving 40 small doses of radiation inaccurately. So the PSA naters after we treat you. So if your PSA starts at 10, by 5 years after treatment, your PSA is 0.1, and most of my patients are really happy with that.
How does the data compare with CyberKnife as opposed to a robotic prostatectomy?
So the patient populations are very different. Usually CyberKnife patients are older and are not good candidates for prostatectomy. Prostatectomy patients are generally younger and generally have more favorable cancers because young guys usually have intermediate grade cancers while the older guys usually have high grade cancers. My general opinion is that the nice thing about surgery is your prostate's gone and your PSA goes to undetectable. I mean, really, really low. It doesn't mean you're cured. You still have to be followed for the rest of your life, but in my opinion, gives the best chance of cure. With radiation, the PSA drops slowly. You still have a prostate in place and your prostate produces PSA. So it goes down to 1 at 1 year, 0.5 2 years following treatment, and 0.1 5 years following treatment. So it's a little bit of anxiety provoking. Sometimes it bounces a little bit. But the nice thing is you still have a prostate. So when you have radiation, usually your orgasm is normal, and you do have a little bit of ejaculate, years after the radiation. When you have your prostate removed, you have no ejaculate that comes out when you orgasm. After radiation, usually you have a little bit. So there's some benefits. I mean, quality of life benefits. There are some benefits to the radiation over the surgery.
Do you find that the incidence of sexual dysfunction and bladder incontinence is a lot less with CyberKnife compared to the prostatectomy?
So bladder incontinence almost never happens with radiation.
But to be clear, when you say radiation, you're referring to CyberKnife?
Yes. Any
Okay.
type of radiation, IMRT, proton therapy, brachytherapy, or CyberKnife, urinary incontinence is very uncommon afterwards.
Right. Good.
And some guys who are very frightened of becoming incontinent, I don't blame them, will choose to have radiation over surgery. Sexual dysfunction after surgery and after radiation are different. Usually after surgery, you lose your erections for a year and they come back to some new normal level that's probably not as good as it was before the surgery.
Mhm.
With the radiation, you have the radiation and your erections are fine for a while, but then they slowly decline over years. The nice thing about radiation-induced erectile dysfunction is that it's very responsive to pills like Viagra, Cialis, and Levitra. So if you have radiation and you're 5 years after radiation and you still have a good libido, Viagra has an 80 to 90% chance of giving you adequate erections. So a lot of men as they're aging, I think, have real life expectations of how good their sexual function is going to be. And taking a pill doesn't bother them that much.
Do you find that patients with CyberKnife are cured?
Okay, so the definition of cure after radiation is dying of something else.
Okay.
So we've treated 2,000 men and we follow all of them. The vast majority of them die of something else and not their prostate cancer. I don't celebrate when one of our patients dies of a heart attack or a stroke, but that is a cure because they did not die of their prostate cancer. Prostate cancer is unique in that way. I mean, if you have lung cancer, pancreas cancer, or a brain tumor, that usually causes your death in months to years. It takes a decade for prostate cancer to cause your death. And usually prostate cancer doctors are pretty good at, even if we don't cure you per se, preventing the cancer from causing your death until you die of something else.
So with everything you've said this evening, what do you say to the young patient with prostate cancer who says, I have many choices here and I have an active sex life at home and I don't want to lose it. And I understand your CyberKnife is a less risk of erectile dysfunction. I prefer to get that over surgery. What do you say to that young patient?
Well, the young patient, I first say that if you're a candidate for active surveillance, that's the best way to not have side effects. If you're young and you're trying to avoid surgery, I always tell them that, I think surgery is the best chance of curing you, but I am capable of partnering with you as a doctor if you choose radiation. The potential risks of radiation are that irradiate you, your PSA will drop. There are 5 out of 100 guys, the cancer can come back in the prostate 10 years later. And it's kind of hard to fix if that happens. Okay. I'll still work with you and we'll try our best, but you can't have a robotic prostatectomy, or the risks of a robotic prostatectomy are higher if you've had radiation. I also tell them that, radiation, there's a risk of secondary cancers, and those secondary cancers don't happen early, they happen late. So they can happen 10, 15, 20 years later. The risk is small, 1 in 100 to 1 in 1,000. We're going to screen you aggressively. We're going to make sure that you get your screening colonoscopies. If you ever have blood in your urine, we're going to check and make sure you don't have bladder cancer. But that's one of my concerns when I treat younger guys. When you have the radiation as a younger guy, generally your penis works a lot better than the 80-year-old guy that I treat. So usually you'll have decreased ejaculate 6 months after, but usually your penis will last for longer because you have more reserve. So, there's guys who are 10 years out after, young guys who are 10 years out after CyberKnife treatment. They're taking Viagra, but their penises are still working.
If somebody 10 years out has recurrence of prostate cancer, can you hit them with the CyberKnife again?
Yeah, that's actually a great point. I think this is an area of active investigation. Like, what is the right thing to do for a man with recurrent prostate cancer after radiation? The most aggressive approach is removing your prostate, but the risk of incontinence is very high. You can do this thing called cryotherapy, where you freeze the prostate. It does have a pretty high rate of toxicity that requires surgical intervention. But we have these new. One of the best things about my job right now is we have these new scans called PSMA scans, and they're PET scans for prostate cancer. They're a specific prostate cancer. In the past, PET scans were mostly used for lung cancer and lymphomas. But now we have PET scans that specifically pick up prostate cancer, and they're showing us exactly where the recurrence is. And I think the future of salvage treatment is going to be using PSMA scans to guide treatment.
Excellent concluding thought. We are out of time. Sean, thank you for an excellent interview. If our viewers have any questions, how can they reach you?
By the way, I love talking to patients. My phone number is 202-444-3062. And Heidi is my administrative assistant. Everybody loves her. And we would love to hear from you because we love being part of the metropolitan area. I have lots of patients from Montgomery County. I love Silver Spring. So I love to meet you guys.
Thanks again for an excellent interview. My thanks to the team at the studio for making the show happen. And my thanks to you, the viewer, for joining us this evening. You can reach me through my practice website at the bottom of the screen if you have any suggested programs for the future. As for our next show, it's going to be a fascinating one. I'll be interviewing a member of the neurology department, MedStar Georgetown, and we'll be discussing acute onset of stroke and acute treatment options. It's going to be an important show. See you then next time for another edition of Housecall. Good evening.